We are your hosts, Nicki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
It's my favorite time of month. Do you know why?
Why?
It's because I get to talk to you. I get to hear your voice again.
That's so sweet.
Yeah. So we've got a fun topic today.
We always have a fun topic, but today's topic is very interesting.
But I'm going to start it. It is, but I want to start it by asking, do you know what E. coli said to Candida after their date?
I don't. What did he say?
That he was a fun guy.
Love it.
Now, I have a question for you. This is a very serious question. Do you say Candida or Candida?
I say Candida, and I have a microbiology background, so I always laugh when people say Candida.
Candida. Well, you know who we're going to ask straight from the horse's mouth? We're going to ask Dr. Jose Cadena and Mrs. Mimi Ford, because we're going to speak with them today about their article. They wrote an article in ACHIC called The Effects of COVID-19 Hospitalization Rates on the Incidence of Hospital-Acquired Candida Central Line-Associated Bloodstream Infection. So let me introduce Dr. Jose Cadena. He's an infectious disease physician with particular interest in the prevention of healthcare-associated infections, antimicrobial stewardship, and novel therapeutics. A medical school graduate from the CES University in Columbia, he also completed internal medicine residency, infectious diseases fellowship, and a year of infection prevention and hospital epidemiology at UT Health Science Center in San Antonio. He is the medical director for infection prevention and works closely with the infection preventionists. He's worked in the field of infection prevention and has published papers related to infection control, process improvement to increase compliance with influenza vaccination, tuberculosis prevention and control among healthcare workers, treatment and epidemiology of methicillin-resistant Staph aureus, and Clostridioides difficile. He has also worked on phase 2 and 3 trials of therapeutics and vaccines for E. coli, C. diff, and therapeutic trials for candidemia and diabetic foot osteomyelitis. He has been part of great research network within the VA and have participated in infection control trials to evaluate surgical site infection prevention, hand hygiene compliance improvement strategies, among others. So that's a lot of work in the IP field. And Mrs. Ford has over 29 years of experience in healthcare with 18 years as an RN. She currently has a master's in public health from American Public University and a Bachelor of Science in Nursing from the University of Texas at Arlington. Mrs. Ford has been an IP program manager for infection prevention at South Texas Veterans Healthcare System, where she started her career with the VA in 2017. She has an extensive critical care and infectious disease background and is a board-certified infection preventionist working in infection prevention for over 8 years. She also holds the CPHQ certification in healthcare quality and the CCRN certification for critical care nursing. Mrs. Ford also has received the Undersecretary for Health's National VA Linda Denko Infection Prevention Award for 2021 for excellence in infection prevention and control, and currently is a quality management consultant for VISN 17, working as a consultant with focus on infection prevention. She has authored an article in the American Journal of Infection Control and has co-authored or authored numerous poster abstracts submitted and accepted by SHE and ID Week with the IDSA. So we're really excited to have you guys. So first things first, I need to hear it from you. Is it Candida or Candida? Dr. Cadena, what do you say?
I vote for Candida.
Candida.
Okay.
That's what we say it. We say it as Candida.
Okay.
Love it.
You've got it. We got different teams. I like it. We gotta have two different teams. It's wonderful. Well, we're really excited to have you guys. Thank you all so much for taking some time out of your very obviously busy schedules to come and talk to us. And well, we'd love for you to kick us off. So, during the COVID-19 pandemic, hospitals across the U.S. reported an increase in central line bloodstream infections, or CLABSIs. And your article describes the incidence of CLABSI rates resulting from Candida species. So start us off by telling us about your paper and what the catalyst was for looking at this particular pathogen. Dr. Cadena, you want to start us off?
We saw a lot of the Candida is the most common cause of central line associated bloodstream infections after bacteria in the U.S. And there was a concern that during the pandemic, patients infected with COVID were getting severe disease, were getting a lot of immunosuppressants, and especially early before vaccines became available, they were becoming critically ill and required long ICU stays. During the ICU, the patients used to receive immunosuppressants to try to suppress the high degree of inflammation in the lung caused by the virus, and as well as broad-spectrum antibiotics and other interventions, and they require prolonged ICU stays. And we started seeing that the number of cases of candidemia was increasing in that population. This was first reported in Italy, where they saw that first wave of COVID. They started seeing not just candidemia, but start seeing also aspergillosis, pulmonary aspergillosis in these patients, suggesting that there was in addition to the viral infection, there was a high degree of immunosuppression. And then, of course, it was very atypical because these patients didn't necessarily have the same risk factors for candidemia that we classically observed. We used to see it a lot in surgical patients that were in long-term immunosuppression, patients with bowel mucosa issues, long-term central lines, and these patients that didn't quite fit all of that necessarily. And then additionally, we saw that these patients were developing candidemia late during the ICU stay. Usually before, the literature used to say that within the first couple of days, the first week was when the patients were more vulnerable after they got admitted into the ICU. But when they looked at the data, they found that this was happening about 2 weeks out of the ICU admission. They observed that in several countries, in several studies. So it became a particular topic of interest.
Thanks so much, Dr. Cadena. Can you also talk about what some of the biggest concerns associated with Candida in specific related to bloodstream infections are? Because we know that there are a number of organisms that we identify in bloodstream infections. So what are our concerns specifically with Candida?
Well, one of them is that candidemia is associated with a sharp increase in mortality. And when the data came in, we realized that the same thing was happening with COVID patients. Now, the question is, was it Candida alone, or Candida was a marker that these patients were in a pretty tenuous situation and they were very sick and their immune system was just not doing well. So they were predisposed to more opportunistic infections like Candida infection. But yeah, the mortality has always been very high.
So while we're on that subject, what were the most common species of the Candida associated with a CLABSI? Is that consistent across hospitals, or was that just a subset?
So, that's a good question. When we started before the pandemic, definitely the most common Candida species was Candida albicans. And still in certain hospitals, it continued to be the most common. But there was a big race in other type of Candida, like Candida glabrata, which, it has always been the second most common. In our facility, at some point, it became the most common. So, and then there was another Candida that is multidrug-resistant called Candida auris, which is kind of the big bad wolf of the Candida world. We don't want to have that because it's can be resistant to many of the first-line therapeutics or antifungals. So, and there were outbreaks in other facilities caused by the fungus. And this one is really resistant to several of the first-line therapies like fluconazole, and it's very hard to eliminate because it's very sturdy. So we saw really a change in the species, kind of a shift during the pandemic, even though Candida albicans continued to be the most common one in most facilities.
And I was intrigued too. There was a noted increase in femoral site selection for central line insertions. Why do you think that was?
It's hard to know. I think femoral site tends to be easier to place. We know that the subclavian side is probably the safest one in terms of preventing a line infection, but it's also the one that requires the better technique, the most experience, and at some points, many of the facilities were staffed with people that was not as experienced as doing regular operations. I think, especially in the first way, in certain facilities, they had to call in nurses from the floor to the ICU and expand the ICU beds dramatically. We saw that in our facility, and it happened in several facilities through the US. Then as the acuity of the disease became less, that kind of corrected, but that was one big point. When you are implementing bundles to prevent healthcare-associated infections, experience and doing the same routine every day in every patient is very important. And when you have to change the staff frequently, there was a lot of attrition of staff as well that left. It was harder to sustain those bundles. And among the bundles, not placing a femoral line is kind of one of the key interventions that we promote. But then when you put a subclavian, you need to make sure that you don't cause any pneumothorax, that you don't cause vascular injury, because it can be a much more severe complications, especially in these patients requiring so much oxygen, like some of these patients did, especially after such a prolonged ICU admission.
Thanks so much. Nicki and I have had a number of conversations about how the pandemic contributed to increased HA. Let's get Mimi involved here. What were some of the elements that you found during the investigation that you think pointed to contributing to these types of increases in CLABSI?
Oh, that's a great discussion. And we had that ourselves. So when we looked at possible factors contributing to our increases, we realized that bedside presence of our core VA critical care providers and experienced critical care nurses were a positive influence within our ICU setting, because we didn't see it really in the ICU. The VA was not immune to the influx of the hardship that COVID-19 had with staff variation and differences in experience, as Dr. Cadena explained. With central lines within various areas of the hospital, there were some areas that didn't have that core experienced staff. Recognizing that our critical care experienced staff positively influenced the bundle compliance with insertion, the bundle maintenance, the dressing change procedures, the provider involvement, it kind of led us to theorize that limiting any one of those factors may have influenced our increases in HAIs during COVID-19 for other areas of the hospital.
That's interesting. These types of things have likely come up in our conversation in past podcasts, as well as just conversations with other IPs. What advice would you give to the listeners to consider within their facility based on what you found during your study?
I think let me add one more thing before we move on to this question. I think the patients were different during this pandemic. There was a complete change in the population that we tended to see, and not so much in the comorbidities, but the older patients got more severe disease. So the patients in the ICU usually are a mix of sorts of different ages, different comorbidities. But when COVID hit, the age went way up, and we were seeing older people in the ICU because they got the more severe disease. The second thing is that we were immunosuppressing these patients on purpose to try to decrease that inflammation that was damaging the lungs and was not allowing us to ventilate them. And then, since they were so sick and they stayed in the ICU so long, when they deteriorated, the clinicians were eager to do anything to help them. And among those things were treating for pneumonias that sometimes were bacterial and required long, broad spectrum antimicrobials, which further increased the risk of candidemia. So, the patients were a big factor in this change. We also saw it with ventilator-associated events and ventilator-associated pneumonias, clinically defined and defined by NHSN. Both ways, we see them raise through the roof at the same time because of the amount of lung damage caused by COVID and the protracted changes in the lung parenchyma that were very hard to differentiate from bacterial superinfections. I think in terms of advice for the listeners, I think it's very important to know that you always have to keep in mind the basics. The going back to a low rate of infections did not require, new technological advancements. It didn't require a lot of things. But when we went back and after the pandemic reevaluated each intervention in each bundle, we realized that they were not being done consistently. And as soon as we got those bundles back up and running every time in every patient, the rates went way down. And right now we have several months without many of these HAIs, including central line infections. So, the hand hygiene and all the other basic interventions are very important to keep in mind. And also, you have to take into account that when there's a big turnover of staff, that each person that comes into the facility, each healthcare worker that starts in an ICU or during a pandemic needs to be trained to be compliant with these bundles. So, that having said that, of course, there was the component of the different population and the different needs that this population had. And really, I would say a different type of HAI, because like I said earlier, is candidemias that occurred due to the central lines occurred really late. They were different to what we were accustomed to. So that lack of familiarity with the infection at the beginning, and then the changing of the characteristics of the infection could have also contributed to the problem. But at the end, I think all we should do and can do is make sure that if we ever face a pandemic again, we keep an eye on the bundles and keep them implementing them on a regular basis to make sure that there's no deviations. And maybe that will help decrease the rates if we ever face an issue like this again.
Yeah, that's a good point. And we'll pivot and talk a little more about all of that and the bundles and such. So, Mimi, hop in here a little bit. Let's talk about how the study was conducted to determine if the COVID-19 pandemic contributed to the incidence of hospital-acquired Candida/Candida CLABSIs. So how was the data? I think Jesse and I switched. I think after we had this little conversation about how to pronounce Candida, we switched. But Mimi, how was the data collected and stratified?
Sure. So this being a retrospective study, we ended up using our surveillance data for our central line associated bloodstream infection program. And after we reviewed, we really noted that we had that increase in our primary identified organism, which was different, as Dr. Cadena pointed out for us with Candida. At that point, we knew we needed to look further into it. We started comparing our past data, prior to COVID-19 from October 2017 to February 2020, there was only one incident of CLABSI with Candida and as a primary organism. However, during the COVID-19 pandemic, we had that increase in CLABSI as the rest of the nation did, right? But during our study period, 27.5% of our CLABSIs were due to Candida species, with the most common being Anglobrata, followed by Candida albicans. And during the COVID-19 pandemic specifically, we looked at data from March 2020 to December 2021 and found that our CLABSIs due to Candida species were higher at 39%, with 16.7 of those with Anglobrata and 11.1 Candida albicans. So not only looking at our increase in CLABSI, as we stratified our data, we also looked at the causative primary organisms, kind of focused on that to see if there were trends. Central line location was a big thing. Units affected, insertion, maintenance bundles. You're looking to see where this is happening. Basically, the normal IP investigation components that IPs do on a regular basis for CLABSI. And then we took it a step further for trends and analysis, making sure that what we were seeing is what we were seeing, right? And during that really busy time, you have all these things happen during COVID, and it can be very difficult for that workload. And as Dr. Cadena explained, you had that differences staffing, but not just for the unit, for IP as well. We were very busy doing all kinds of other things, and focused on those CLABSI preventions.
As part of the study, were you able to determine how much of the incidence of Candida CLABSI increased with respect to COVID-19 at a national level or for your own hospitals?
So that's a difficult question. Researchers are still looking into this as far as at a national level. We know from the CDC HAI progress reports reviewing data during 2021, comparative to previous for CLABSI, they still found that standardized infection ratios nationally were still higher. Specifically, they also noted that during 2021, quarter two, there was a drop. And that coincidence with the dramatic reduction in nationwide COVID-19 hospitalizations. But there again, there was an increase in 2021 Q3 as hospitalizations increased. So we kind of found the similar. During our spikes of COVID-19 hospitalizations, we again had opportunities for improvement for CLABSI prevention. But for specific Canada CLABSI at the national level, we need to look at the CDC when they release more current data through NHSN. I think we will find that there are increases in Canada CLABSI during that time period. And I believe Dr. Cadena kind of explained or expanded upon some of that. However, as mentioned in our study, Canada CLABSI incidence significantly increased for us from the pre-COVID to the COVID periods. We went from 0.06 versus 0.77 per 1,000 central line days. And so we certainly found that concern with Candida species. And it's an area of expanding interest, really and truly, as our facilities are able to look retrospectively, at their own data. And so, we at the VA, we certainly always are looking for that other cause or other, mitigation strategies that we can focus on. And so for this, that Canada CLABSI incidence really did help us get to improvement mechanisms.
Interesting.
Right,
Thank you.
right. And it is very interesting. And as you're kind of parsing all that data out, did you identify patient risk factors that were that contributed to yeast BSIs?
Sure. So, in general, clinically, patients with severity of comorbidities, increased hospitalization days, invasive device usage can possibly contribute. As Dr. Cadena talked about with our COVID patients, they were on that immunosuppression. They were on all of those medications to try and combat COVID itself. Not all of our Candida CLABSIs or all of our fungemia were with COVID at the same time. Not all of them were, but some of them were. So that was certainly a concern for us. And that is truly a developing thing as well, looking at COVID with Candida specific. However, for our studies specifically, we did not find a risk factor that contributed, rather a sequel of scenarios for those admitted to acute care during an increase in COVID-19 hospitalizations. If they had a femoral site selection, for example, or if there were concerns with the bundle compliance during insertion or maintenance, those were the type of factors that may have contributed to their risk during our study period. However, again, we did not find a specific risk factor that contributed to the Candida BSI in our facility other than those mentioned, for the timing of admission. It seemed like that was the big sequel of if you were admitted during a time of high COVID-19 hospitalizations, you had an increase.
Right. Yeah. And interestingly, the article also noted that there was an association between COVID-19 acute care hospitalizations and Candida CLABSIs, but not in the general ICU hospitalizations. Do you have any thoughts on why that might have been?
Yeah, so that was really interesting and a surprise for us. We had no significant association between COVID-19 ICU hospitalizations and Candida CLABSI. And so that was a very interesting point. But as you mentioned, what we did find was that we had a significant association with acute care data, showing that association with acute care hospitalization. And, our core ICU nurses, our core critical care providers, those stayed within those units. And I think that experience level, staying in those units as, we were trying to pull staffing from everywhere, as I'm sure every hospital did, right? You're pulling staffing from everywhere that may not be as familiar. I think Dr. Cadena mentioned that mechanical memory. When you're changing that central line dressing and you're used to doing it with the same equipment, with the same kind of dressing kits in the same scenarios, you have that muscle memory and that experience level because you've done it hundreds of times. I think that really helped our ICUs because we did not see that association in the ICUs. Whereas our acute care, we're pulling staff from everywhere that could work acute care. So this meant a gap for us and an opportunity where we were able to focus needed attention for staff reinforcement of bundle compliance improvements, increasing adherence, improving documentation, and, ensuring that that supply chain challenges. So anytime the supply chain had to change kits to a different manufacturer because you're trying to pull in supply from everywhere you can get it from, right? That was a big thing during COVID.
Mm-hmm.
We had to make sure staff understood what they were working with, that the kit is a little different. Maybe the CHG is going to be in a different place. Does this dressing have CHG within the tegaderm? Is it impermeated? Do I have to get a bio disc? It depended, right? And during this time, we really had to pull on deferring to expertise is a big thing with the VA. We always talk about deferring to expertise. So we had to pull in our vascular nurses. We had lots of conversations with our vascular nurses that were putting in PICC lines, putting in midlines, making sure that they had eyes on other patients. Like when you're walking through that unit, hey, put eyes on the central lines. Just keep looking. Our nursing educators were a big help to us during all of this. A lot of them got pulled onto the floor, got taken out of their education role, and got put to the floor because of staffing needs. And that kind of helped us and hurt us, right? Because they weren't able to do their necessary nursing education function. But here they were having to do it on the fly on the units while they had patients, making sure that staff that weren't as familiar could become familiar. And so it really does broaden, how things happen. But it did give us that ability to apply data to the front line.
There's so many factors that are going into that, all the variables, because you've got, like you said, you've got staff that aren't in their regular area, and you've got all these supply changes. And, I don't know if people were going to put in central lines and, there was an element missing and that they were, somebody needed to go back out. Were they breaking sterile field and were they taking down their sterile field and restarting it? Or was this kind of like oh my gosh, we just need to get this line in? You talk about non-adherence to the bundle elements in the article, and I can imagine how many factors went into that. Do you know what specific elements that were more frequently missed? Do you know about those variables? What can you tell us about that?
Yeah. So, bundle compliance is one of the core elements, right? And there's a long list of things that you need to have done. During our study period, we had multidisciplinary involvement as we thoroughly reviewed all the aspects of the insertion checklist, the dressing change procedures, the maintenance bundles. And we recognized challenges with hand hygiene, especially when removing or replacing gloves. And remember the time that we're doing this, that isolation, particularly with COVID patients, sometimes you'd have a whole ward on isolation. So that, removing, replacing gloves, basic, you think about it as the basic function, but sometimes it was being missed, and that could have contributed. Maintenance of intact dressings. The intact dressings were some of our key factors that gave us opportunities to focus on prevention efforts and lead us to improvements facility-wide, really, because as we started pulling in all of those disciplines to say, hey, everybody start looking at these central lines, start looking at these dressings. Then we started to say, hey, this dressing isn't staying intact. This dressing from this manufacturer may not have been the best choice for a central line. Let's make sure that they're intact better, longer. Make sure the dressings are appropriate. So hand hygiene, basic. And as infection preventionists, we find it can be one of the most core elements that can contribute to our chain of infection.
You see this increase in stuff, and when you've got a pandemic going on and all of this other education and new staff and people being pulled, and what a nightmare it was. So
yeah, and picking up the pieces. Yeah, and I think too, this is why we always talk about a bundle is meant to be a combined effort of all of those elements, right? And so missing one element may, it may be a contributor to an infection. And so how important it is that we do all of the elements every time, because it does get complicated. So Mimi, tell us what you learned from your investigation that you think led to improvements in your hospital.
Yeah. So, in general, I have to say what we really learned is that organisms never take a break. We have to always be vigilant as the next organism's right around that corner. And it's willing to cause harm. We just never know when that's happening. And so looking at your data, constantly looking at your infection data, are there trends? Are there, multiple primary organisms that you're seeing that you don't normally see? For our study, it was Candida, that, like I said, had not really been present in our CLABSIs prior to this. This experience led us to push forward with a lot more interdisciplinary and multi-departmental involvements. As you both have mentioned in previous podcasts, the collaboration needed to have instrumental change, it just never goes away. It just never goes away. And for us, our bedside healthcare workers, particularly our VA nurses, I just have to say, I'm a big cheerleader for them because, as we just celebrated Nurses Week this past May, there are foundational champions for zero harm. And when you get them to be your IP champion, when you spend more time with nurses at the bedside explaining this is why we do this is why we do that, whichever bundles you're talking about, whether you're talking about CAUTI, catheter-associated urinary tract infections, just keeping, that loop, that dependent loop, not being dependent, and explaining the why, taking the time to educate. So when you get the frontline nurses behind you, they are your biggest champions. And for us, our VA nurses, and with that catalyst from our frontline staff, we were really able to make positive interventional change that has stayed with us. We all remember, COVID-19 was difficult and it was hard and it was stressful. And I'm sure as there's more studies that come out, there's some traumatic experiences that we all probably share in commonality as nurses. And so we learned a lot. I will just say, it's a simple phrase to say that we learned a lot, but we really did. And I think for me personally, reaching out to such different specialties, the PICC nurses, I tell you, there's nobody that knows a better sterile technique and aseptic technique. I love our PICC nurses. I just can't say enough how valuable they were to us during this period for CLABSI prevention, for basic vascular care. And we've actually pivoted at South Texas, looking at bacteremias with CLABSI. So, you look at that and then you start adding, hey, is it a midline? Is it a peripheral IV? So we've actually started to include our peripheral IV into that prevalence check, into that process to see if any of our bacteremias are related to PIVs. And that's something that is new. And so at our facility, we're always trying to push for that zero harm.
Yeah. And I think, to your point, there's always something to be learned, right? We continue to evolve and learn and study and look at studies like this to help make improvements across our organizations. And to your other point about the staff, something that I was recently talking with someone about was the importance of, looking at the processes on the units, going out and actually seeing how things are done, because I think sometimes we try to make these isolated changes to processes thinking, they should do it this way, and not really fully understanding the logistics out there on the floor. So I think having those collaborative conversations, as you mentioned, and really integrating all of the stakeholders into our teams when we're updating and building education and doing, making changes to processes. I think all of these are so important. And I think Nicki and I just want to thank you so much for being with us today and sharing the work that you've done and offering all of your insights around that.
Well, thank you so much for having me and reading the article. It's really been fun, and I listen to you guys' podcast all the time. Thank you.
Thank you.
Thank you for joining us today. We are Nicki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Pat Stone and Jean Brandt at AJIC and APIC staff, Rebecca Bartles, Ria Gupta, Bobby Gulshan, and Liz Garman. We work in partnership with Human Factor and audio techs Blake Alton and Carolyn Schneer. To hear other AJIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, ajicscienceintopractice.org. That's AJIC scienceintopractice.org.